unit within the sustainable, within NHS England and Public Health England. So we cover some strategic policy support for NHS England, Public Health England and the care system on commissioning sustainably and delivering services sustainably. I'm joined by my colleague David Pension, who's the director of the unit, Jessica Allen from UCL, and Andrew Burnell from Hull, from a community interest company delivering community services up there. So what I think we'll do is we'll go straight into presentations from myself and David to start with. David's going to talk about what does social value mean in the health sector, and I'll talk a little bit about a module that we've published recently on social value and how it can be applied in the health and care sector. And then we'll move on to Andrew and Jessica, who will focus on some of her work around the social determinants of health. What I'd like to do is, if it's okay with you, is probably take clarification questions after each presentation rather than discussion questions, if that makes sense. And then maybe at the end, after we've done all the presentations, we'll have a kind of a panel discussion, if that works. Is that okay? Yep. All right, well, let's kick off. So David, you can introduce yourself. Biographies are in the pack as well if people need further detail.
Fantastic. Okay. My name is David Pension. Thanks for the introduction. Has everybody heard of the NHS? Yes? Good. Anybody work with the NHS, for the NHS? Really? Is that all? Okay. Has anybody ever been a patient with the NHS? Good. Fantastic. Lovely. Okay. So what I'm just going to briefly talk about is the overview of the work that, as Dave said, not just in the NHS, but in the, let's say, the health and care system. Because as you know, the NHS is only one determinant of health. If you look at the increase in life expectancy since the Second World War in this country, which has been significant, you can't attribute it all to the NHS. So I just want to put the work we're trying to do on social value of the health and care sector. And as a shorthand, I'll just say the NHS for the time being, although, as Dave said, we do try and have a system-wide approach to both the NHS, Public Health England, social care, and a lot of other agencies that are absolutely central to improving health and care. Earlier, about exactly a year ago, we published a strategy across NHS England, Public Health England, and with colleagues like the LGA around what it is that the health and care system can do to promote health, not just be an illness factory, promote health in our communities and places. And that's quite a big call, because that's not actually the NHS isn't terribly interested in health. Okay, it's fascinated by disease, but it's not terribly interested in health. Okay, when I was at medical school, I never went to a lecture which ever said, these are the causes of health. Okay, it's taken me sort of 40 years to struggle with understanding what is it that causes health in a way that someone like Amartya Sen would understand, in terms of helping us lead lives we have reason to value, helping us lead lives we feel we have reasonable control over, issues like power, like Victor was saying. So as part of that, there's a part of the NHS England PHE which Dave and I work in, which is around how do we deliver the best possible services now, but how do we do them in ways that A, are fair to the future, i.e. that we don't deliver high quality services now, but at a terrible cost to the future. And that's largely about our environmental sustainability approaches, but also in terms of, actually, you know what? We're about 10% of GDP. We employ 1.3 to 2 million people. We've got a procurement budget of £20 billion. Excuse me, could we be using this in really creative ways rather than just running these big factories on the bypass where the A&E gets blocked up? We could do a lot more. So I'm not saying we are doing a lot more, but we're certainly conscious of both our opportunity and our responsibility. And I'll just show you one slide about how we might be doing that, or a couple of slides, and then I'll hand over to Dave to go into some of the details of one of the modules we've written, a few copies of which I have here, about the role of the NHS in adding social value, which is what we're talking about today. So essentially, what we're doing is we're trying to enable the positive things that the health and care system do. That's on the left. That's about improving the natural environment on which all our health depends. And that's everything from not flushing drugs down the loo to making sure that our carbon emissions are within environmental limits. Okay, and that means a lot. I mean, this is the only country in the world, that has ever tried to measure its scopes 1, 2, and 3 carbon emissions. Okay, and we've done that 3 times. Okay, now what that means is that we have the carbon emissions, for instance, if you're interested, of a small country just in the NHS. About a third of all public sector carbon emissions come from the health and care sector alone. A third. Okay, now we do a lot of good things, but that's a high cost. That's a high environmental cost, as well as the significant financial cost that the health and care sector costs, £119 billion of your money and mine. So natural environment, social assets, independence and well-being. And what we're trying to do to reduce the negative side of it is reduce the environmental impacts, reduce unacceptable inequalities, and reduce the huge burden of preventable disease. Okay, that's everything from obesity to diabetes. You know, if I took you around the wards of my local hospital, I could show you the degree of preventability in almost every hospital bed there and in every GP clinic. Okay, so let's try and factor social value into this. So, and what we're trying to do with colleagues from NEF, and Alison is here in the audience if you want to speak to her after. I think you're doing a session this afternoon, are you? Yeah. So one of the things we're trying to do is adopt not just a single bottom line to health and care delivery, which is how much health and care are we getting per buck, the financial bit, and that's obviously very important. And in a sense, that's represented by that circle. You know, how do we what are the financially viable services we can deliver to improve health and care? Okay, what's the best value for money? Best value for money. If we want to help, you know, produce the best possible hip replacement, how do you do it with the least possible cost? Okay, to improve the quality of care, to reduce the, you know, burden of disease and illness. But actually, when you think about it, we are a huge employer, 1.32 million people, significant buyer, an important exemplar. You know, what the health service does visibly is important. And I'll just cite you one example of that. People in this country did not stop smoking until health professionals stopped smoking. Okay? We all have weird habits, and I don't want to know about any of your weird habits or mine, but we justify them in the most interesting and creative ways. And so if you see something like the health service, which is central to civic society in this country, taking absolutely no action on the big issues of our time, be it obesity, be it social value, be it about fair employer, be it about adding environmental protection, then how can you possibly expect people to say, try and take it seriously in their own lives and their own homes and their own workplaces? I mean, I suspect that most people who work in the health service do a lot more, are good corporate citizens at home, and when they come to work, you think, oh God, it's just so difficult. You know, I'm a pawn of the environment in which I find myself in my surgery or hospital or commissioning organisation. So we're an influential partner, we're a huge educator and trainer. We spend billions of pounds training people. And we have a huge estate, one of the largest estates in Europe. So would you not think that in addition to financially viable services being provided, we could be socially responsible in the way in which we improve health and provide care? Okay? And that's not the direct, that's the way in which we do this. That's the way in which we provide care, the way in which we engage people, patients, the way in which we engage procurers. So let me give you one little example to make this real. And there are a couple more examples in this very short module here, which Dave has been the architect of, about how the health system can create social value. In Nottingham, it's got 2 big hospitals. Now, the NHS is the biggest buyer of food in this country. Okay. What do? Now, there are certain ways if you run a hospital, you can buy food. You can have a contract with a big factory in South Wales, which will chill food and crate it across the country all through the night. Okay, so you get a pre-packaged, cooked, chill food. Or, if you want to, you can try and do something locally. Phew, that's hard work. But in Nottingham, what they've done is they've gone out, they've engaged local farmers and local food producers, very small often, and that's really hard graft. That's very, very difficult. So in Nottingham, they quantify how much food they buy locally, freshly, and even organically, how many people they employ, how many Nottingham pounds are kept in the Nottingham economy. Okay? But it does not stop there. What they also do is they say, well, actually, it's actually quite a lot of work to prepare this food in our hospitals. So let's train some people in our hospitals. So let's train people in our hospitals to do the preparation of this food who are not normally easy to get into employment. People with learning difficulties, people who need qualifications, people who need a step on the ladder to independence. So they do that as well. And they quantify this. And this has been so successful that not only have they saved their trust money, but actually they're so efficient in the way they produce food, they've got a contract with the local authority to provide all the Meals on Wheels too. Okay, and that's partnership. That's the partnership. So that's just one example of how you think creatively about these virtuous cycles. You can do good upon good upon good. And that's something that I would hold my hand up and say, actually, as the country is actually Europe's largest employer, we don't really fully exploit that potential to add social value in the way the NHS does its business, because it's so tough at the moment just doing the day job. Okay, it's really tough. If you're a frontline health worker, you barely have time to find the light switch to switch it off, let alone think creatively about procurement and EU rules and all the other myths that may well get in the way of the energy. So that's the second part, and so that, and one of the really, really important points, and that's why it's really important that Jessica's here, is that if you are a direct provider of healthcare, great, you can do some great things. You can prescribe drugs, you can do operations, you can help people live with cancer. It's great things. But if you really want to address another part of the health domain, which is not just the raising of the mean level of health, but the contraction of avoidable health inequalities, making it fairer as well as better, it's almost undoubtedly that by that indirect route of being a socially responsible system, you will address health inequalities more, better, faster, in a more sustained way than you will through the direct provision of services. Okay, and that's why it's great that we've got units like Jessica's, who you'll hear from in a second, about doing that. And that's all about, you know, the Marmot agenda, where the health service has got a really powerful role. Okay, and this includes increasing personal health and resilience. It includes increasing community health and resilience. And that's exactly what is it about in terms of doing things with people, looking at an asset-based approach. We're incredibly good in the NHS of looking down, being paternalistic, you know, doing healthcare to people, not promoting health with people. That's not a language that's familiar within the health service. You know, this is historical. That's the product of our history, really. And so all that is what I'd call the large health domain. And the other part of it, which we won't be talking about as much today, which is being environmentally responsible for the improvement of health and care. Okay? So on the left, that first blue one is the single bottom line. Are you getting good bang for bucks? Being socially responsible is the double bottom line approach. But actually what we really want to aspire to is that triple bottom line of, can we provide high quality services, add as much social value as possible in doing so, and do it within environmental limits. Okay, and there's a whole other narrative, very powerful narrative of why we should do that, being between, you know, doing it environmentally sustainably, which we don't have time to go on today now, but if you want to grab me over lunch, I'll explain that. So that's the background, and what we're going to do now is to explain how that will create conditions which A, we have much more control over our lives, and B, we can live lives we have reason to value, a direct quotation from Amartya Sen. So, Dave is now going to spend a few seconds just talking about the particular module, about how we're hoping to take this forward. And I've got a few copies of that, so if you're into the business of collecting paper, I'm very happy to sell you one of those, to give you one of those in a bit later. Okay.
Thanks, David. So one of the questions we always get asked when we go around, when we were doing the module, was what is social value? And one of the answers that we've come up with is it's not about what it is, it's about how services are designed and delivered. It doesn't really matter the definition of it. But for the sake of argument, we went through some definitions just to be robust in the module. So what it is, we've got definitions referring from wider non-financial impacts of programs, including well-being, to social capital. And we heard earlier this morning about the 4 capitals that I think, was it Andrew was talking about? Yeah. Then the definition within the Public Services Act, you'll all be familiar with that, so I won't labour it. And it's a way of thinking how scarce resources are allocated and used, and involves looking beyond the price of individual contract and look at the collective value. The consultation that we did on this, one other theme that came up very strongly was that social value is about outcomes, and outcomes are about what matter to people. And to understand what matters to people, one has to engage and consult with them. And you'll see some of that in the recommendations that we've put forward in the module. So how did we get here? We had desktop reviews of the best practice available. Important also to recognise that social value is not a new concept, really. Local authorities have been doing a version of social capital for quite some time. We had Total Place and other initiatives to try and bring things together. So it is not we're not starting from this position. There is a long legacy of bureaucrats, commissioners and providers trying to get their heads around this. The whole antecedents of foundation trusts were built on this premise of engaging with local communities and designing services that were relevant to their local needs. Now, we'll have a debate later perhaps about whether that's had any impact or not, and whether it's just created free market monsters, but we can talk about that later. We had case study submissions from Vanguard sites. My word, Vanguard, I know it's in the 5-year forward view now as well, but these were sites that were kind of leading the way, Halton, Nottinghamshire and so on. We had a national consultation process. Anybody get involved in that? Anybody submit a submission? No? Okay, maybe that's a failure on our behalf. Cross-sector steering group reviewed evidence and consultation feedback. So we had a steering group of leaders within this field, or perceived leaders within this field, who took us on a journey through the different things that we needed to consider as part of the module consultation. And then we identified the key themes and we anchored them to practical examples. So what will follow this module is a set of implementation notes in the next couple of weeks, which will have some further case studies. So the feedback was in 3 areas. There was strategic feedback, practical feedback, and measurement feedback. So these were the key elements that were identified as being important. From bottom-up measurement, which Victor Adebowale mentioned this morning as being quite central to social value gaining wider traction. And that's a common theme as well from what we heard nationally from organisations. How do we measure it? How will you recognise the tools that we measure, and so on? And it's a reasonably complex area, so perhaps we can kind of explore some of that during the panel discussion too. Practically, about having a cross-sector policy steering group to develop the evidence base, review best practice, and to disseminate that more wider. And again, it'd be useful to have some feedback from you when we come to a discussion shortly about what would be useful from such a forum, what works for you underground, trying to access information around social value implementation. And the strategic social values embedded in health and care system governance structure. So one of the ways, well, I'll talk about some of the ways that we're doing that or recommending we do it. So organisations across the system have regularly assessed their local area and genuinely work to build stronger communities through effective partnerships. So collaboration was also a feature from the plenary discussion that we had this morning. And we think that's absolutely central to how social value is embedded. And we're particularly interested within the Sustainable Development Unit about the emerging contracting models that are coming forward from commissioning, about how we can bring providers together to collaborate in a more stronger way to integrate their services. So I'm thinking about alliance contracts, the use of Sequin, for those who are familiar with Sequin, as a method of driving change. Commissioners and providers routinely use a tested framework for designing and implementing initiatives which have a demonstrable and positive impact on social value. So it'd be useful to hear Jessica's perspectives on the use of the equality impact assessment, which is one of the things we heard back in the consultation might be a framework to try and get people to assess the impact of their social value endeavours at the very outset. and to have that formally built into an EQIA. It's a start. It might not be ideal, but it'd be useful to have some perspectives on that too. So the practical cross-sector coordination and SDMPs. Who's familiar with SDMPs? Sustainable Development Management Plans. Anybody familiar? No. Well, those are plans that are embedded in the outcomes framework within the public health outcomes framework for organisations to develop a sustainable development management plan, which outlines their plans to improve their approaches to maintaining sustainable practices. And we're recommending that social value is included as part of that. All organisations will have one by the end of this year. And I've talked about SDMPs. And then the measurement one, the really tricky one, it feels. Tools for measuring and evaluating social value are commonly used by organisations and in local systems of care. The unit convene a metric steering group who coordinate our metrics across most of our environmental domains, and we'll be looking to embed social value into that and get some, that's a very considered piece of work which we think will take probably about 18 months to get some traction, and NEF are supporting us with visualising how that might look. Okay, so any questions of clarification, particularly just on that quick jog through? I managed to squeeze it into, well, just over 5 minutes. All right, should we move on? Oh yeah, sure.
Before I go into social enterprise, I used to work in collaborative outsourcing for some large corporations. And collaboration is always a very difficult one with demarcation, also in terms of legality, whether or not it's collaboration with a capital C and a small c. And by that I mean it's just that how far of a demarcation line do you give in terms of the spirit of the agreement versus what you're legally bound to deliver. How does the NHS work in that area? Because that's actually quite a complex area, having spent a lot of my life in that domain.
Well, I think it's a great question. I think it's probably one for the panel. So can you hold on to it and then we'll come back to it when we're all seated. Andrew, do you want to go? Maybe give us some practical views after we've done the strategy. Yeah. So there's some contact details for us. We'll get these slides out and about to the group anyway. Phil, have you got Andrew's? So do you want to introduce yourself, Andrew, and let us know where you're from?
Can everybody hear me? Yeah, where am I from? I feel like a bit of deja vu, actually, because I'm standing here in front of you now, and 13 years ago, I had the job in the regional office in Northern Yorkshire to lead on health improvement, health inequalities through the NHS plan, of which what we tried to do then was persuade large acute trusts, mental health trusts, to be sustainable and to be part of a community and to add in their value to the local economy. So if you looked at Jimmy's in Leeds, that's a hell of a lot of billions of pounds that they ignore the fact that next door to them is one of the most deprived communities in the whole of Leeds, of which I happen to live. So actually at the end of the day, and then 17 years before that, I came into the NHS as a nurse. So what I don't actually recognise is the fact that, like, what I did recognise was that everybody I looked after was a product of much more than just the illness that you saw in the bed. So I made my way through my nursing career, and I've been a health visitor, I've been a mental health nurse, I've been a general nurse, I've been a manager, I've been whatever, and now I happen to be Chief Exec of City Healthcare Partnership CIC, based in Hull. And I have to say now it's a company based in Hull, because we're not just in Hull anymore, we're in East Riding, North East Links, Lincolnshire, Merseyside, Guernsey, and Europe and Australia, hopefully, where I can go and live. Now, well, why not? We've been to Hull. The thing with it is that it's everybody's business. And one thing that I just wanted to say very quickly is I had to leave the NHS to do some of this, and that's telling. So there's a question there. Why is that? And it's maybe just due to something about what we've heard and how the NHS tries to do things and dictates things and puts things in frameworks that then become, what they then become is it becomes something I've got to do. It's not something I want to do, because actually it's something that actually means something. Now, one of the things for us is that social value in our business is really important. And I was there sat this morning listening to Interserve and all that. Fantastic, great, good on you lads. We didn't need an act to tell us that we were going to lose our business if we don't do social value. Social value was set right at the beginning of our journey because our staff ourselves are drawn from the communities in which we work, so you can't lose sight of that. And those communities are important because those communities are people like their relatives, their mums and dads, their friends, etc. And they actually want to play an active part. So if you take health out of the community and the person, they start losing something. And actually, at the end of the day, what we decided was to give more. How do you take 1,200 people at that time and say, actually, you're going to do more than what we did in the NHS and we're going to add more value? And one of the things that when we talked to the staff and talked to the community about was this idea that actually, at the end of the day, being a community interest company was something that was really important for us because actually, it says what it says on the tin. It's a community interest company. It's about the community and it's about an interest and it's broader than what you just do. So, who are we? We're a co-owned. We're a co-owned business. That means that all the staff have a £1 share. Mutual is the new term. And not every member of staff has one because I keep saying this, we're from Yorkshire and there's out for now. You've got to pay £1 and not a lot of people want to give up a quid. You might laugh. It is perfectly true. They think you're going to do something really, they'll never get it back. They don't get any profit, so it's not like, I'm paying 12% to serve shareholders before I do anything about care and looking after the environment. Everything is invested back into profit. All the profit we make is put back into the services, the community and the staff. And that's what I call for better profit. I don't call it not for profit, because if you're not for profit, you're bankrupt. And I agree with Victor. Look, I might stand up here, be all sort of like socially, and I don't wear sandals, I'm not into muesli. And at the end of the day, it's about business, this, okay? It's about hard-nosed freaking business, right? So let's dispel any of this nicety stuff, but it makes bloody sense, because actually it gets everybody on side about what you're trying to do. And actually, when you are drawn from community, when you actually got to work like this is the point that actually get it. Early 1980s, I'm not going into when, but when I came into this, I'm actually doing the job that I came into now. So now I have to be chief exec of something, I have to leave the NHS, leave nursing, and actually I'm now thinking that I'm doing the job that I came in to do, which is look after people properly. Because I'm not managing upwards, I'm managing outwards, and I'm managing to deliver. I ain't got people knocking on my door saying, here's a foot on your neck, what you're doing. It's actually about delivery. So we're socially motivated, diversified portfolio of services. We've got our registered charity now. We invest in the service staff and community, like it says there, in which we work. Our mission, to grow a socially responsible commercial business, and I don't mince words around that, we need to be commercial, and we use commercial principles. Somebody did say to me, it was actually RCN, said, how can you as a nurse be a business leader of this CIC? You're a nurse, for God's sake. I said, well, my view is that there's about 1,200 people in this business that are actually entrepreneurial, and we just never allow them to be, and we never allow them to use their ideas. The system wants to put them down. It keeps them in little boxes. I was actually told I was a bit of a nuisance and I'd never go very far because I open my gob, and like I'm doing here, and probably get myself into a lot of trouble, but I ain't got any puppet masters telling me what I can and can't say, so I'm not bothered. And actually, we've got higher quality safe services, responsive, caring, inclusive of all, and really importantly, a place where people love to work. Because actually, I agree with that, if people don't love working for you, right, they don't do their job well, all right? And if they don't do their job well, then poor people at the end of it, swimming in need, get a crap service. So actually, it's got to be a place where people love to work, and we work really, really hard. And I tell you, this bit about social value, it ain't some bloody tick box thing on a thing or squeeze it into whatever. They get it, and they're happier because they get it. Because they're happier because they're doing something that actually is really, really important. I don't care what you want to measure it by. If they're happy, the outcome's better. So, anyway, that's me, that bit. Anyway, we've got 4 very, very key, and we've had them for 5 years. We left the NHS in 2010, so we nearly come 5 years. We're all out to tender at the moment, so there was my competition sat on the old board there this morning, Interserve, Virgin, the rest of them, come and take us on. Because you can go, honestly, you're not having it. You know why you're not having it? Because there's 940 people who've got a share right, and you're going to take their business off them. Think about that. If somebody come and take my business off me, I'll be a bit pissed off. And I won't want to love to work there anymore, because actually I've got something bought into it. Anyway, put our customers and customer satisfaction out of what we do, able to compete, like I said. There's some lovely staff, they're all very happy. Be an employer of choice, be a provider of excellence in healthcare services. Nothing wrong with them, is there? We're not changing them. And do you know what? 74% of our staff filled out their staff survey, and 87% recognise the mission, vision and values of the organisation. Anybody else get that figure? Oh, well done. Well done, that's really great, mate. I'll have to talk to you later. Interserve. I'll have to be careful, aren't I? I'm like, I'm going too far. No. Oh, that's good. I like that one. I have to remember that. Anyway, some key facts about our business. And I don't say it's my business, it's our business. We left 46 million, we're now 67 million. That's over sort of around about 10% growth. We went from 2 contracts, we've got 27 now. We've got staff numbers, we're growing. Tell me which NHS organisation in your area is employing. Well, we are now more nursing staff because of things that have happened in the service, but we've been growing ever since we left when we were restricting. We even recruit and retain. And one of the things we're doing at the moment is our local authority have just stripped 1.2 million out of our sexual health budget. Anybody else recognise that? We're supposed to be protecting public health, but at the end of the day, what we're doing there is we're using the redundancy money to train all our healthcare assistants to become nurses for the future, because we've got a problem. Nobody, you know, if you've been to Hull, it goes from motorway down to an A road, and we've got to look after our own because people don't commute very well. Like fine wine, we don't commute out very well sometimes. Anyway, shareholders, we've now got about 930. We had 400 when we started, and we've got a social return on investment. Now, when we started, we measured it. We got £1 for £2.30, and I was over at Moon. Hooray, well done. We now got 33 quid. And that's because we've taken a journey over the last 5 years and been sophisticated, and I'll explain why and how we measure that. So we've got 65% of our profits go back into our services, and most importantly, we majored on our procurement because we had about 4.8 million that was going externally. We've now got about 85% of that goes internally, and we've got all our like little providers and things that we get a better service. So I agree with that, you know, and actually you get cheaper service. I'm not being funny, but actually you can sack them off as well. And if they're bad and they compete against each other, you get a better outcome. And it's about local economy and about measuring what you do. So it's across the board in the organisation. The thing about social return on investment, the social value. It's not just about how you provide. It's extra bang for buck. Not just for the commissioner, but for the people that live there. So why is it important in Hull? Well, those of you like me who've done a bit of public health in the past, dabbled, that ain't a very good graph. I can't read what it says on it, but actually at the end of the day, Marfleet, St Andrews, there's a lot more red, isn't there, than like nice blue and purpley type areas. But as most people will probably know, Hull's got some sort of like, I always say deprived problems, but it ain't, it's deprivation problems, isn't it? And at the end of the day, it's got this huge big issue. So really, at the end of the day, we've now got, like, one of the things that was important for us right at the beginning was how do we secure our future? How do we move forward? And this thing about actually doing much more than what you do with your pound that you get is really, really important. It's always been really important, really strong within the organisation. Staff get it, staff see it, like I've said, and it's about putting back into where we are. Now, we do that now over in Merseyside, we do that on the North Bank, we do that in East Riding. We can demonstrate each where we land. We actually invest in, beyond the contract, into local voluntary sector groups, into staff, into sort of like, into just doing things in a different way. So we call it our social life, and basically we aim to make sure that it's our differentiation in some respects from where we've been. What is it we can do? This is more differentiated from where we were within the NHS, but also about the fact, actually, at the end of the day, how can we get the staff and ourselves to feel that like, we're a key part? And we have this strategy called the Weave. I came up with that really great idea. Basically what it was it's a bit of a cool trick. What we said was, way back in 2010, we need to be intricately interwoven in the space-time fabric of Hull, East Riding and everywhere that we are, so that when you unpick something, say you unpick district nursing and you want to put it out to the market, the whole bloody thing starts to unravel. Because actually everything is intricately interwoven into economic, social, you know, environmental, into the real, so we're into everything. There's nothing that we're not into. We're City of Culture, we're in that. Freedom Festival, we're into that. We sponsor the rugby, because all the young kids over in that deprived area, part of the area, we get them in to do rugby, we're into the football, we can get all our blinking messages across, even though we're probably going to go down. So ticket value and the price of my sponsorship will have to drop. But it's really important for us. It's not just about like having a corporate thing. It's about how you share it around, how you give it to the community to get engaged, how you then take those businesses with you to say, actually, you can do something different. And we've had suppliers work with us now who've become sort of like mutuals, who've started to think, how do I actually contribute more? But I think what we tend to forget is in the public sector, the amount of private sector, local businesses in your local area who are so entrepreneurial about doing some of this stuff, and how do you capitalise on those in your supply chain? Because there's some that do great stuff. They don't even think about it. The lads and lasses bought up on estates that just say, I just give back, I just employ people from this local area because like, they need a job. And you find that once you sort of like get out of your office and get out there. But and we're also sort of like part of the skills pledge. We've got apprenticeship schemes. The local authorities just pull the money on the apprenticeship scheme, but we're going to fund it because we've had some fantastic value out of some of the young people. NEETs, not in education and training. We've had a couple of them now in jobs. We've got like little Carl there. He's now doing a degree. He started a lad who couldn't get a job with us, and he's now in HR. Some brill stuff, some great people, but it's part of our role to sort of like give back. We measure it through this social return on investment. We use a social accountants. We don't just do it ourselves, by the way, because we could just make it up, and we would. We would just look, well, you know, it won't be £1 to £133, it'd be £1 to 99 quid, wouldn't it? Let's be real. And it's just like doing your accounts, isn't it? We take it that seriously. You know, these are externally go to our partnership forum with our community, they go to our executive board, they're poured over, they're looked at, they're very, very important. We've got now 5 years virtually of sort of like measures about where we've been. And this is a framework, 3 years, that's been put together 2008 by the Cabinet Office. So it really sort of like makes me think, well, hang on a minute, you've got this already, and you can measure all sorts with this. And it's not just one measure, because what we do is we do the quantitative and the qualitative stuff as well. Because the stories, the little vignettes about like what somebody, like the lad who couldn't speak at school when we sent him to go and do some horse riding lessons because that's what he'd want to do, and now from his autism he's speaking. Hang on, that story is really powerful. So when the health visitors and all that see all that sort of like stuff, they're like, well, hang on a minute, this is like, you know, I've seen an impact on what we do beyond. So actually, there is a measure there, so I don't know what we keep going on about, let's devise measures. There's loads of them, but they're all different. But this one's one that the government's done, so I don't know why we're trying to reinvent the wheel, or maybe I'm missing something. Probably correctly, I'm missing something, because, you know, I'm a simple lad. But anyway, so 33 to £1 social return on investment. We've got fundraising, which we do through our lottery, which is with our hospice, and we give something back to the hospice for that. And we've got our charity now, the City Health Partnership Foundation, and all the staff get involved in raising money through that. And we have actually distributed more than that now in terms of staff sponsorship and grants. And I think somebody said this morning, and I think it was that chap from Interserve saying, like, you know, well, you get more out of staff. You actually do, don't you? I mean, at the end of the day, investing that bit in them and sponsoring to go to Africa to build a primary care centre, God, we've had so much more back than actually just the couple of grand we've paid for them to go and do it. And they become back better citizens, they come back better individuals, work as well with a different ethos to do things in a different way. I mean, there's loads of people sat in this room that do this better than we do, but at the end of the day, I just think it's just phenomenal, some of the stuff that we get back. And here's just how our ownership makes a difference. And what we measure is we measure our services as well. So we go across from what you buy from us, we'll measure that externally, to there's our sustainable travel. We bucked the trend. Got in a bit of trouble with trade unions, like, but we altered terms and conditions on travel because actually it rewarded those who had bigger burning fuel guzzling cars than those that were more efficient. So if you rode a bike, you only got about 5 pence per 50 mile. If you had a nice big sort of like V8, sort of like Daimler, you know, like Jaguar or whatever, you got like 58, 60 pence a mile. So that all inverted. So actually now you get paid a lot more for having a fuel efficient car. We've got, for every pound in terms of what we're trying to save or invest in that, we've got a £127 return on that. Evolves our eating disorders service. Our supply chain is for every pound. Our carers information service is 31 to a pound. And like I said, there's some of the organisations. So there's a Melita Walker there who ran, who does, so that's all about, she's raising money for infant health based on perinatal mental health. And a chap, one of our lads up in project manager there, rode, I think, from sort of like Hull to Brough and raised a lot of money. Well, that's only about 10 miles, by the way. He didn't. He cycled coast to coast or something. But anyway, I think that's probably a question, and I was left with it, but I won't answer it now because I've taken up too much time. Thank you very much.
Thanks, Andrew. I think that's a YouTube hit in the making somehow. Can I introduce Jessica from UCL? Before I do that, are there any questions of clarification that people want to put forward now before Jessica speaks? No? Okay, great. Thanks again, Andrew. Phil, have you got Jessica's? Great, thank you. Thanks, Jessica.
Is this going to make a hanging noise, this tube of accessorising, possibly? If it does, let me know and I'll remove it. Right, so I work at UCL Institute of Health Equity, which is Michael Marmot's unit, and we wrote and researched for the Marmot Review, and since 2010 when it was published we've been busy trying to implement the findings. We've had quite a bit of success nationally advising governments and influencing public health, and a bit around the NHS. And we've had some success locally, which I'll talk about in terms of getting the approach that we advocate in relation to health inequalities implemented. Today I'll just talk a bit about what we mean when we talk about health inequalities and what they are. And then I'll talk about a piece of work that we've been doing for PHE around the Social Value Act in relation to health and health inequalities. Hopefully most of you are familiar with this. It's a map that was a graph that was in the Marmot Review. Along the bottom you've got neighbourhoods, a measure of neighbourhood deprivation, the most deprived on this side near me, and the wealthiest, least deprived, on the far side there. And all those dark green dots are neighbourhoods. This is the top tranche of, the pale green dots, that's life expectancy. And you can see several things. First of all, that the more deprived neighbourhoods have much lower life expectancy, and obviously the wealthier neighbourhoods have higher life expectancy, and that there's a gradient in this. It's not just the difference between the top and the bottom. All of us in this room are somewhere on this gradient, so we're all suffering from some degree of unnecessary health inequality, in this case shortened life expectancy, of course, unless you're incredibly wealthy and living in the wealthiest neighbourhoods, and the Queen, for example, she seems to go on forever. Prince Philip going on forever, outdoing most male life expectancy in the country. But for most of us in this room, we're all somewhere on that gradient. This is crackling, isn't it? I will remove it. It's plastic. So the dark green dots, that's a measure of health. That's disability-free life expectancy, so how long you can expect to live without a life-limiting disability. Again, you can see much lower rates for the more deprived neighbourhoods, and people living much longer in good health in the wealthiest neighbourhoods. You can see that there's a bigger gap as well on this left-hand side of the graph. People are living much longer in ill health, living shorter lives and living much longer in poor health, having a life-limiting disability to around 50. The likelihood anyway, not absolute figures, but the likelihood of having a life-limiting disability around 50, it's well over 70 in the wealthiest neighbourhoods. So that's another really stark inequality, and we find this on all kinds of measures. This is just life expectancy, disability-free life expectancy. We find this gradient in everything. When I came to do this work, I was astonished. Lots and lots of the outcomes that we look at have this gradient. In early years, for example, how often children are read to, spoken to, cuddled. Social class gradient, I was astonished. So, the recommendations from the Marmot Review, as David said, none of them specifically relate to healthcare, because the NHS is one of the most equitable systems in the world. We know that, and the Commonwealth Fund reports on that annually, I think, and every time the NHS comes across as the most equitable healthcare delivery organisation in the world. And there are inequalities in access and outcomes, particularly outcomes, but they're not major, and they're certainly not responsible for those inequalities which you saw in the previous slide. So these are the 6 areas in which we made recommendations, and we have reams of evidence now showing that it's experience and quality of early years, it's education, that's a tranche of recommendations around B. C, fair employment and good quality work. Ensuring a healthy standard of living, that's about money. You can't be very healthy if you're really poor. Even in England, there's relative levels of poverty which are very low and mean that people cannot live healthily. And finally, the 5th one, healthy places, very important across the whole of life. And finally, we got onto public health and we made some recommendations. And in those recommendations, we talked about the causes of the behaviours which cause ill health. So we often hear a lot of focus from public health generally around smoking, alcohol, obesity, which are the causes of a lot of ill health in this country and a cause of a lot of those inequalities. But what's driving those? There are clear inequalities in all those behaviours, and we talk about the causes of those illnesses, and the causes of the causes lie in the social economic fabric. I said we'd been doing some implementation of the recommendations of the Marmot Review. We were pleased that the King's Fund did a survey of the priorities from health and wellbeing boards and found that the principles which we advocated, the social determinants of health principles, are prioritised by most of the health and wellbeing boards that they looked at. So that's great. And we found that we're working with a number of local authorities across England supporting their efforts and so on. And of course, it's all very well to have this as a strategic objective. Public Health England have it as a strategic objective, NHS, DH, so on. But we really need to see it in practical implementation, and we get asked all the time, and we're trying to do this now, to what to do. So we have practical interventions about how to tackle health inequalities locally and at national level. So what can we do? What's cost effective? That's become an increasingly pressing question, of course. This notions of social return on investment and so on. So we were pleased when the Social Value Act, the provisions of the Social Value Act were highlighted to us, because in an area where there are very few levers actually, there's a lot of goodwill and ambition and strategic directions around health inequalities, but very little hard levers. So we were pleased that we were able to make this connection between the provisions of the Social Value Act and health inequalities, because it is a lever locally and it is a lever nationally as well. And it's important to remember the national leadership role which the government and all the departments of the government have in terms of their own spending and so on. There are other levers. There's the health inequalities legislation, which was embedded secretly in the Health and Social Care Act and actually places a onus on, no, not an onus, a requirement, a duty and an obligation, a legal duty on the whole NHS to consider health inequalities in all the decisions that they make. I haven't got the words right, but there is a legal definition, and it is a reasonably strong legislative requirement. It's really underplayed. Very few places are aware of it. It has begun to exercise the leadership within the NHS and Department of Health, which is a good thing because it means that health inequalities are prioritised. But again, it's not the strongest bit of legislation in the world. So that's the other lever, really, the legislative lever. But the Social Value Act, as you know, can be used, has been used. We've had lots of good examples already just now, and I'm sure there have been lots throughout the day. There will be lots throughout the day about use of the Social Value Act to improve the economic, social, environmental well-being. That's one definition. I know there are several, and as I was pointed out, the definitions don't really matter because we know the gist of what the Social Value Act means, and we kind of know social value. So, to make the connections with health inequalities, and this hasn't been done hugely extensively, particularly in CCGs, although David was saying that there are good examples, and we know that some areas have really taken this on and made huge progress, which is great. But across the country, not huge progress really around NHS and CCGs taking up the Social Value Act explicitly in their procurement. So we'd like to see social value defined in relation to reducing health inequalities and improvements in health. So we know not huge uptake nationally, to put it mildly. The government, we went to a Cabinet Office meeting where the Cabinet Office sat around pulling their hair out. What are local areas doing? What are they doing? What are you doing? Well, we're looking at local areas. Actually, there's a requirement across government for the government departments to look at their spending and so on, and that's not been well developed. And we see much more activity and action locally. But I'd like to not forget that nationally there is, this is underdeveloped. The NHS England might be a notable exception. Department of Health have done quite a lot actually. CLG, I'm not so sure. Pressure on government departments politically as well, I think, is helpful. There have been various surveys that found some measures of success locally. A lot of places tell us that they were doing this anyway and they've just rebranded it according to the provisions of the Social Value Act, which is all good. And there are some areas which have taken it up as a result of the Social Value Act. So we make the case in this work that we're doing with PHE that implementing the Provisions of Social Value Act can have a very, very positive effect on the social determinants of health. We've seen how this, so if you're investing locally in areas related to employment, employing local people, that is a health inequalities intervention. So sorry. So Blackburn and Derwent, for example, they had a look at their local procurement from the public health budget and found that most of it was going down south, out of one of the poorest areas. They were losing their public health allocation, which was weighted according to their level of deprivation. It was all coming down to Southampton or something where they had cheaper sharpeners, stationery. So they changed some of their procurement practices and are spending the money locally on the understanding that local employment and investing locally will, of course, regenerate the area, improve employment, and that is a health intervention. Reducing needs, that's a health inequalities intervention. So we take a very broad view of health and the measures required to reduce health inequalities. I've moaned about national implementation, but there is some, and it does apply to them. And DH has to run this helpful programme which has supported many areas in taking a social value act, so there are some good notable exceptions, but on the whole I think national government have been a bit lagging. So we've been working with various areas and they've been telling us what they've been doing. Salford, here's from Salford, have got a multi-agency partnership. They talk about themselves as a social value city. It's fantastic. They're doing some really good innovative work. I won't spend too long dwelling exactly what they've done. Halton often held up as a good exemplar, which it is, and it involves the CCG leading a lot of this work, which is great because I've mentioned that's not wide-scale across the country, CCG involvement in this, but they've got this very broad-brush partnership, which is great. It's also a very small area, Halton, so they're able to do some really quite extensive things in quite a small area. And they make a very broad social value definition, improving individual environmental economic well-being to reduce inequalities, and reducing inequalities will reduce health inequalities because these are the inequalities are driving the levels of health inequalities that we see. Lots of challenges, of course, and I'm sure you could add to this list some lack of clarity, lack of clout. We're not sure how far this legislation's been tested, but there is a lack of clout. Definitely a lack of accountability in national leadership, I think, which is a challenge. Some of the issues around measurement, but as has been pointed out, there are measures which are effective. I'll just add to that, though, that it's difficult to build in equity into these social returns on investment. That's a problem that we have. You can make a kind of assessment of social return on investment, but getting the kind of where it's impacting and how is more challenging. It can be done, but it's more challenging. And in all these kind of interventions, getting the distributional elements of policies and interventions right to tackle inequalities is hard. So, and measuring it is hard too. Making the case, we hear time and time again that it's got to be, and this is a new thing, of course, for public health, politically acceptable. They've got to convince the councillors. The political leadership won't move unless there's a very clear case. They can have demonstrable social return on investment figures and so on. And public health quite new to all of this, and that's been quite challenging for public health anyway. Procurement, we hear many times that the approaches of the procurement teams, the training, the culture is different. It's quite hard to get them on board and they're swamped and it's very difficult. And you go with one more thing, can you look at social value? Can you add in social value? And there's a general groaning and it takes a big organisational change and cultural change and also technical abilities. So a lot of capacity building needs to happen as well. And we hear repeatedly that that is a major challenge still. We're talking about the impact on social value of disinvestment, because of course that's a lot of the activity now is around disinvestment and cuts. So social value can be used helpfully to advise what's being cut. What will be the social value impact of that? So some of these approaches are being used in terms of decommissioning and disinvestment, which is not how it was intended, obviously, but it is actually a very valid assessment to be undertaken when considering disinvestment. There's confusion in some areas around the Act, what it does say, there's lots of exclusions, and there's EU legislation, so it is challenging again to get through some legal hurdles. And actually, if you put in your contracts that this money must be spent locally, you're contravening some other EU legislation. So there are some really difficult, there's ways around it, but there are some quite serious legal obstacles around implementing this. Success, it's a slightly shorter list, but I should add to it, I'm sure you can. Local leadership. In every case that where we've been talking to people, local leadership has been absolutely key to getting the procurement teams on board, getting the political support, getting all the teams involved, getting the required partnerships, and that's absolutely central. And of course, that only happens in some areas, this kind of good leadership, and we need to think of ways of making this happen across those areas which are lagging behind a bit in relation to social value. And it's not easy when so much does rely on some very good leaders who aren't replicable necessarily. Building on local narrative and existing priorities, that's been a key factor in success, not reinventing the wheel here. We're saying this is our priority and this is a way we can achieve this priority by using Social Value Act legislation and approaches. And that's really helped areas get the sort of local support and cultures that are needed. Community engagement and communication, consulting with the community at every stage of the process, that's been a key factor for success, which has been identified to us. Clear vision throughout the partnerships, and again this point about measurement, which you've heard. So it's a good opportunity. We're very pleased about the Social Value Act, and as David pointed out, there seemed to be quite a good alignment of things, at least in the NHS at the moment. There is a Social Value Act, there's the health inequalities duties, there's a focus on health improvement, because everybody realises that treatment is a lot more expensive than prevention, and we can only really achieve sustainability in the NHS if we reduce demand through health improvement and reducing health inequalities. So there are some positive signs, I think, within the NHS and nationally in other policies around this. We've made the point about working the economic case, the economic power of public procurement, and I think again that requires, as David's pointing out, within the NHS that's not been done. So I think the NHS might be a bit of a laggard in this regard, but also local authorities with this sort of municipal culture might have been doing this much more thoroughly for a while. But it is a very important case to make, particularly at the moment. Opportunity aligned with other priorities and obligations, particularly actually a helpful focus on inequalities more broadly. From where we sit, there's a lot of focus on income and wealth inequalities, and a very strong narrative. Even the OECD and IMF are talking about inequalities being too deep, and we need to hitch health inequalities, which we know are so closely associated, onto that to make a much more powerful narrative about the effects of inequalities on all of us. And of course, one of the other levers is a legal obligation, which is good, and we need those kind of obligations in order to get the required changes and reductions in health inequalities. So thank you very much.
Well, I asked Jessica, David and Andrew maybe to have a seat on the Graham Norton show, I suppose, or something. Have I? Well, we'll get the cabinet out. Graham Norton or Jeremy Paxman, one or the other. Any questions on technical level for Jessica, just before we move into panel discussion? We've got a question from the front from earlier. No? Should we fire straight away into questions then? Has anybody got a direct question you want to ask? Do you want to go first, since you had one from earlier?
I was asking earlier about collaboration in terms of how you do that in terms of social enterprise. And the reason I'm asking is that I'm moving from an industry where with very much commercial collaboration is about mutual benefit and ultimately making sure that the profit is reached by the outsourcing company. In social enterprise, one would imagine, particularly with a small one like me, we look after children and adolescents on the autistic spectrum. We look at things that we can do for our local community and add value and do things like as simple as keep adolescents out of the criminal justice system when they try and self-medicate. But all this is a grey area in terms of a demarcation line, in terms of a service. How do you manage that from an NHS perspective?
Well, I wondered whether, I mean, it was one of the questions I had for Andrew about whether all the focus, we heard a lot about commissioning, and actually providers have a real key role to run with and to be freed up to run with social value approaches, and professionals, which was your point, Andrew. And I wondered if you have any thoughts about what those barriers are and how we could break them down.
I was trying to work out the question from the first time about, because I don't see any mystery from a provision point of view. I see actually strength in the ability to. I mean, we provide a lot of things, but we don't do some of it very well, and neither do we do everything. So we've recently just won the prime provider contract for our anxiety depression service, and it's the first one we've won, and we've had to reconfigure how we run the business to make sure that we're fair and equitable to the providers that we've actually gained on our supply chain in some respects. But we're looking at that supply chain in terms of collaboration, partnership, working more about how we take those values throughout that, but also what do people put back in locally, and can we work together to create a more sustainable pot of provision by us working on each other's strengths and weaknesses in some respects. I don't know whether that answers the question, but
it does sort of, but I guess that also goes back to Jessica's point in terms of the fact that there's got to be measures, and I would have thought that as a sector, we are surely best placed to, arguably above all sectors, to actually lay down some golden laws about what these measures should look like, and actually get and have some real life working examples. And the reason I guess that's important for where I'm coming from, when I sit down with the local health professionals and the local provisioning services, the local health authorities, they want to go through various tick boxes and say, okay, these are our measures, this is what we're measuring you and your company by. France is, how can you guarantee that you're living up to our expectations? And at the moment, that argument, that discussion, if you like, comes down to some quantitative measures and some qualitative measures with anecdotes and that kind of good stuff. And you come out of that meeting having sold them something and sold them a degree of satisfaction, if you will. But I guess sometimes the feedback you get is, well, next time could we have it a bit more hard-nosed? And I want to take it there, but they have no universal measures, so we end up making them up.
Well, it's a really interesting point, because we got 1,000, I think it's 1,780 at the last count, measures in one contract alone. And that doesn't, none of them measure any of this. None of them measure anything that says, is that outcome been better for that child, parent, community? And I think where our commission is trying to get to, which I really fully put my, support through their whole 2020 vision, is working collaboratively with everybody that provides public sector to look at a range of outcomes, which is different to where we are at the moment, and people going about efficiency. I've got a full team that just work on every month for 2 weeks, giving people reams of paper that actually does it have an impact on that graph on that overall health inequality of the area. It might mean that somebody's had a bandage done in a certain period of time or had a leg dressed, but are they back at work? Are they active in the community? Are they actually promoting economic regeneration and adding extra value to the local area? I think you're right. I think we've got to get much more. We've talked about it for years, and I think what we need to seize the nettle on is what is a range of outcomes that actually is going to add value to the public sector in terms of all the new public sector, as Victor was talking about, in terms of what is this, what do the public expect, or what do the people that use our service expect from us, more than what do bureaucrats like ourselves set ourselves measures that are going to measure something that's immaterial to them? Because they see a lot of things, don't they? People want to save the NHS from what mediocrity at the moment, if we're not careful, and we've got to really and in parts it's not actually helping people, so we've got to, what do the people actually want, and how do we actually open up to them to say, what's our dialogue with you about what you can actually achieve? Because I don't think there's enough money in the system for people to expect what they expect at the moment, and that's the real big problem that we're facing, is this blindness to the fact that it's the community, it's got to look after the community, and it's us that've got to help facilitate them to do that, and the NHS and everybody, the local authority. Not about, I will procure that, because actually what's that? That don't mean out, does it? To that young lad who can't get a tier 4 mental health bed or whatever. Nothing.
Okay, thanks, anybody else want to comment on that? Question down there at the back from lady in the middle.
Thank you. Liz Allen, an organisation called The Connectives, which is a social enterprise, so I ask this question as a devil's advocate, really. If we really want to address inequalities and use the Social Value Act to do that, does it matter who's delivering the services? Does it matter whether it's Interserve or Serco or a socially driven mutual business which is providing local employment for local people?
Who wants to take that? Jessica?
In our view, and it's kind of painful to say, I don't think it does matter. If you're looking at the outcomes, you just want to achieve those outcomes. So often, social enterprise is best placed because they've got this at the core, they understand social value and so on. But actually, in terms of delivering the outcomes more broadly on inequalities in a local area, I don't think it does matter. Now, there are obviously a scale and so on. So we hear many times that small organisations can't tender for contracts because it's so complicated. So that seems like it's an unfair practice, whereas a big private sector, they've got reams of people doing exactly that. So if there's something about supporting local organisations to be able to compete on a level playing field. But beyond that, I think who is delivering the best outcomes really is what should be the criteria. I'm not sure if that's...
It looks like he's got an opinion.
Yeah.
Well, it's a great question. I do get asked it, and I suppose it comes down to a societal point of view, isn't it? It depends what you want to do. What we were just talking about people and communities, and if you give people and communities the proper response, do you want all your money that you've put into tax to be paid into looking after elderly young people, and that money be utilised in the most effective and efficient way locally, or do you want to see some of that money not do that actually? Because actually what you're doing is you're differentially moving some of that out of the area to pay shareholders or whatever. I suppose it depends which side of the coin you want to fall down on. So there's not a right and a wrong answer. I think I agree that outcomes are important and good service, and I think we should hold some of these big providers to account for how they're spending public sector money. That needs to be the thing, and that's a level playing field, not just because I'm Serco and I've got millions and millions and billions of pounds so I can have a whole unit and link with every university in the land to make my business look better, because we can all make our business look better. I could make it up, like I said, but actually, what's the system look like in terms of that measure? How are we going to measure people? What's the range, and actually what's the value behind that? But actually, what do you want? Because actually, I find it absolutely unbelievable, right, that Hull can afford 12% of what is a decreasing rapidly budget going down the A63 and out of it. Because I just think there's not enough money to provide what we need to provide now. But we need to capitalise on all that money that we've got. We need people that are going to add value back in, who are drawn from them communities to work with the community. So I'm not evangelical about it. I mean, I just think that sometimes we've got to wake up. We've had too many people rob us. So at the end of the day, I think it's more about how do we actually, as guardians of that in some respects, I have to stand up for what I believe in, and that's it. I just think we should use what people give us in the best way possible. And I just don't think some points in the capitalist system at the moment, even though I've been called a rampant capitalist, I've actually worked in the benefit of the communities of which now they've been pillaged. And we've got lots of unemployment and that. We need to work together to make that right, not make it disappear. And those that make a lot of money out of this stuff need to start waking up and looking at themselves, saying, hang on a minute, I live on my island. Well, great, but everybody where I am is getting a crap service. So actually, how do we, it's what do you want? Sorry, did I answer the question? Well, a bit. But.
Well, I think I did, yeah. There's a gentleman here, and I've got another question here, and are you still looking to come in? Okay, so we'll take, I see you at the back as well.
Tom Levitt, I'm a writer and consultant on cross-sector working. I'm also a former MP, and I get very angry when I see my former colleagues willy-waving about who's going to be able to spend more on the NHS than the others, because ultimately the viability of the NHS is not going to be achieved by throwing more and more at the supply side, but about managing the demand side, which is where the social value principles come in. So my question, I think, is probably for David. You said that we'd all got personal experience of the NHS, but most of us don't have that experience very often. We're not generally in touch with the NHS. We have much more experience of the workplace and our employers. And I'm thinking in terms of not just musculoskeletal disorders or stress, but even what goes on in the works canteen. Can we not invest more, if you like, if that's the right word, in making employers have duties of healthcare and producing social value by not just their workforce but their communities as well, and promoting healthy values.
Yeah, absolutely. No, I can agree more, Tom. And it's one of the supreme ironies, actually, that, I mean, Simon Stevens, who's the chief executive of the NHS, has just actually written this personal 5-year forward view and proposed some of the things that actually are potentials that we're really not exploiting. One of them is this, that why is it that 1.3 million people, there are people within 20 yards of everybody in this country who's an NHS member of staff. Why are they not ambassadors for health in their own communities? Why are they not exemplars? And actually, Simon's proposed some pretty radical things for things like what should be the weight of staff. And that does send out a really important message. You know, if we have, and both in terms of helping staff and actually penalising NHS organisations who do not provide good workplace practices for their staff. So that is a really, really important point. However, the irony is, if you look at one measure of how content and how willing staff are to give more widely to their communities, which is volunteering, okay? My understanding is that the rates of volunteering in NHS staff are remarkably low. They're tiny, yeah. And probably the reason for that is that most of us feel like we're volunteering most of the time anyway, because we are probably not adequately rewarded. We know we're one of the best low-pay employers in the country. And so we have a huge responsibility organisationally to our staff. And then, of course, you come on to some even bigger structural paradoxes, which, when you think about the bigger system, which is most NHS organisations are not even financially incentivised to improve health. Okay? You don't get rewarded for improving health. In fact, you almost monetise illness. You almost monetise illness. So there are some really fantastic schemes around the country whereby NHS trusts are asked to get involved with illness prevention. And of course, the first thing that strikes the finance director is, whoa, hold on a second, this is threatening our business model here. So one of the things we really need creatively is how do we incentivise healthcare systems to improve health, to prevent if it's preventable, why is it not prevented? There's absolutely no point of a blocked A&E department saying, oh, we're blocked, you know. So where's the grit on the road? Where are the handrails in the homes? What is in fact, in Merseyside, the fire service and fire rescue service is doing more to put in home aids than the NHS. So where is the joined upness of the system? And it is remarkable, however, you know, well-meaning we may all be, Tom, but it's amazing how quickly people can say, oh, not my budget, not my problem, not my system. I mean, these are highly paid professionals who have social consciences that cannot see beyond the confines of their own organisation into the larger system. So I agree, it is a really sad thing. And one of the advantages of Andrew is that sometimes you have to go outside the system to be innovative. It is incredibly difficult to be innovative in the NHS at the moment when you're being... Sorry, but is this being recorded? Or, you're not tweeting any of this, are you? But I mean... Okay, great. Well, hello, Mum. But seriously, there is an issue about a lot of people within the health service feel absolutely constrained. They do great things in their private lives, but feel absolutely crushed in their professional lives because the idea of, you know, strategic planning is to reach the end of the clinic, not to think about the health inequalities of the communities we serve. And that's terrible. If we're doing that to 1.3 million staff, what hope is there? And actually, the great advantage of having CICs or what have you is that you can say, let them go to Nottingham, let them go to Hull, let them go to Merseyside and see how these things can be done. These are real ways of doing so. And why we can't incorporate this sort of creativity and more novel, well-aligned business models in the NHS is very, very, is a tragedy. We're not doing it. I agree entirely, Tom.
We've got time for maybe 3-4 more questions. So here at the back, here at front, and here in the front as well.
Hi, Boo Dendy, Leading Lives. I've got some observations and a question for Andrew. Fantastic presentation, I really enjoyed that, and there was a lot that I could relate to as being a nursing assistant 20 plus years ago, and now a policy advisor and vice chair of an employee-owned social enterprise that span out of the local authority. We deliver support to adult social care. Interestingly, we have the same problem with people not wanting to give up £1 for their share and a vote. Interestingly, some of that changed when us members and the board voted not to give a dividend to those that weren't members. The power of the £20 cooperative voucher. You made reference to social return on investment as if perhaps every home should have one. Otherwise you'd be making it up yourself. Last time I looked, that was probably going to cost upward of about 15 grand. I'm interested to, excuse the pun, know what value you put on that report, as opposed to perhaps just applying some of those tools that exist within it. And how important is it to you to have that particular method to demonstrate your social return?
I think having worked in the system and then not worked in the system, there's always somebody then going to come and knock on your door to say, demonstrate what you do and how you do it and why you do it. And way back 5 years ago, we were searching for a methodology that could give some. And what you've got to remember is we were set up by the PCT with a board that looked like a foundation trust, which I always put as being platinum FTSE 100 coated and very expensive. What does it do? And actually, at the end of the day, we've moved all that to something that delivers. But it was really taking people that had some of this ethos around I'm here to do this, to actually say, well, no, actually, it's just as important about measuring quality, about finance, as measuring what impact we have as an organisation. So whether I said every house should have one, I didn't mean it like that, but it was something that we chose at that point in time as something that would be a consistent measure for ourselves, not like the education measures that they move around and then people look bad. It was actually say, how can we measure ourselves on a year-by-year basis to show that we're developing? How can we then develop that with the people that do it with us in terms of like looking at what we do? We're also looking at trying to take that and use it internally as well, so that we will train up people internally to do it as well, so that actually we can reduce some of that, but so people even get it more into the core of what they do and how they do it. So it's about starting a journey, somewhere that actually at the end of the day you're just trying to put something on. And how important has it become now that you get the Social Value Act in, and then you get sort of like people like our commissioners saying, actually, we like what you deliver. Can you prove it? Well, yeah, we've got these figures, and they go, actually, they look robust, and they've got a level of them. So I think that it was just something that started a process really about actually, and I'm not saying we might change it somewhere down the line, but at the moment it seems to measure what we do and it gives us a consistency. We're at a point where we need to demonstrate that consistency to our commissioners and others as well, that's what we do. But we also said that we would always prove it back to the staff that we said we'd do what we did when we left, and they seem to accept that as a methodology.
Can I ask what it cost you?
It probably costs a little bit more than what it was going to cost you, but can I just say that like we made provision from that right from day one as being something that was important. We don't go scrabbling around trying to find it. I said right. We left and I had a director of social business and public relations, and nobody else did. And the reason why was that part of that business, our part of that business, the core needed to be very strong. So we have invested in it, and that's just a choice.
Where did you get your proxies from and how were they tested?
Can I maybe ask for that to be a lunchtime question for Andrew? I think that's fairly detailed, but I guess the point that Andrew's making, which I think I would echo from the consultation, is that find a measure that works for you and the people you're accountable to, be both users and commissioners if that's the case, and then use it. It doesn't have to be social return investment. There are other methodologies. So just 3 other quick questions. So one question here, and another question there from that lady, and a gentleman at the back.
Richard Williams, not Interserve. Sorry, I work for a National Council for Voluntary Organisations. But what I just wanted to focus really David, I think it's either both Davids, is really about, there's lots of talk about strategic, practical measures. That's great. That's all very good. What's been done to address the real challenge, which is the behavioural challenge, changing behaviours in procurement, and actually also, which I think Andrew touched on, that issue around scale, which is so important in how you get people to act differently?
Yeah, I'm not a procurement specialist, and there are people in the audience who are better and more experienced, and people who, spend their whole careers in this business. From my observation of the procurement process, and correct me if I'm wrong, there is a sort of immaturity to the dialogue in procurement. So, for instance, if you say this is broadly the service I want to commission, and I want to test whether anybody can deliver it and quantify the social value they add as well. Okay, and people say, well, what do you mean by social value? What's the measurement? How would they? And you think, well, I don't know actually. I want you to be creative. I want the contracting process to be a dialogue. Impress me. And we don't do that enough. We simply don't do. One of the things I think we're very guilty of doing in the health service is micromanaging the commissioning process to say, this is exactly what we want. This is how many hip replacements we want. We're actually not really concerned that there's collateral damage in the way that's done. And I think all credit to the much more innovative, if you like, commercial world that exists, to say, are you sure you want that? Because come back to the outcomes. What are the outcomes you're trying to specify? If that's the outcomes you want, you may be trying to commission the wrong processes or widgets in order to do that. And many of you will probably know there's a whole movement about outcomes-based commissioning, where the process is you give the people who are supplying the service, either in partnership or on their own or with others or in the third sector, actually an opportunity to say, if that's really what you want, actually the evidence says we can do it another way by, for instance, really involving the user, the person with a mental illness, really involving them in actually what they want. And I know that's happened in various places around the country. Lambeth is a good example in terms of the mental illness services in Lambeth. Genuinely not just outcomes as defined by professionals, but outcomes as defined by the people who are actually at the hard end of the service. So I suspect, although I would preface it by saying I'm not an expert, that we have a terribly parental approach to commissioning, when we're not actually untapping the creativity of whichever sector is willing to offer the service. That's my...
I'm glad you said whichever sector, because all I'd ask you to do is not be seduced by the private sector, because some
No,
of the
I
most
wouldn't be.
dysfunctional organisations I've come across actually are in the private sector. They just hide it better, because they daren't to tell people, because they're actually share value that goes through the floor and a whole range of issues.
Yeah.
Okay. Right, thank you. This lady here.
Hi, I'm Chris Tully, Chief Executive of a company called Ripples.
Just repeat that again, your chief.
I'm Chris Tully, Chief Executive of Ripples, community interest company. I spun out just after Andrew, actually, as part of the mutuals we are now. And just to say that, I've been working for 50 years in the NHS, and I know coming out 4 years ago, we've been able to do amazing things as social enterprises, a small social enterprise. And we could, before I was always penalised for saving money, taking it off me if I did as a good manager, put it somewhere else, then I was told to do less. But now as a community interest company, we can do more. We've put back into our community, and we do prove that. I mean, what worries me, I suppose, going into the future is, I'd say, in commissioners, we'll look at, what value, added value, social value we can give, which we do, and if we're in competition with private sector, and we've been in there, we're tendering now, and in competition with people who've got lots of money, but not, are they going to look at the social value we can give? And we do, and we prove it over and over again because it's our company. And you see the people who have come out of the NHS, and I'm not saying knocking the NHS because we've got a lot of good things out of it. I trained, I was a nurse, but now we've come out, we're able to innovate and really prove what we do. And the ones who have come out of the NHS, I just think we're amazing. I'm retiring now, and I just want to say a thank you to everybody for the input we've done over the last few years and shown a real difference, and especially Andrew, a very inspiring guy, I'm sorry. So, anyway, sorry. Yeah.
I suppose just while we move to the gentleman at the back, I mean, David made the point, and all the panel have made the point about some of the rules that govern NHS organisations versus those that are independent are arcane. I work as a commissioning director 4 days a week for a London-based CCG, and we find it very difficult to move money off our books where we have an underspend into NHS organisations because they can't defer it forward, whereas we can do that with voluntary sector organisations, and we need more of them to be able to do that and manage those rules and be creative about it. So there's some absurd underpinnings that will slowly be washed out, I think, as we have more of these conversations. Maybe the final question from the back, and then we can have some lunch.
Thanks. Tim Hayward, who's the Finance Director and the Head of Sustainability of Interserve. Just thought that I'd just... Well, no, I think it's a little bit easy to define this discussion in terms of competition, and there are elements within the public sector, the not-for-profit sector, the commercial sector, which are very easy targets and are inefficient and not delivering the services, the value propositions, the ethics, or whatever. And, you know, I get a little bit upset personally, I have to say, about the demonisation of the commercial sector in public and in politicians, but let's move beyond that. And I think to say that actually what success will look like is when we can move beyond the sort of the partisan ideological discussions about what is the best origin of capital and investment, be it taxpayers, be it communities, be it shareholders, and onto what is actually the best delivery. And what I'd like to point towards as a maybe route for the future is what we've been doing with the probation services through Purple Futures, which is a genuine collaboration of public, private and third sector. And the idea, it was held through public procurement, but the supply chain that we put together is one of genuine multi-sectoral collaboration. And I think, you know, the less we start talking about rapacious capitalist bastards, inefficient public sector layabouts, good for nothing sandal wearing charities, the better, frankly, because actually we're all in it for, as Lord Adebayo was saying, for the best outcome and the best service. And, you know, let's open our minds to other ways of doing things.
Point well made. David and I in the unit talk about Jeff Mulligan's collaborative state quite a bit. You know, there's no third sector or private sector or state sector. There is a collaborative intermeshing and internetworking of providers and services from different sectors delivering outcomes that matter to people. So it's a fair point. Thank you all for your contribution. Thanks to the panel, to Andrew for coming from Hull. Jessica, thank you, and David. Thank you. See you over lunch.